Brother Spearman, if you'd open us up with a word of prayer.
Sure. Everyone will bow their heads. Heavenly Father, we humbly thank you for all the blessings you bestowed upon us. Thank you, Lord, for family and friends. Lord, go with us this evening to this blessed informational session. In Christ, our demon sake's name. Amen.
Amen.
Thank you, Brother Spearman. Good evening, everyone. My name is Alexander Jones, and I'm the boss list of the Epsilon Iota chapter of Omega Psi-Phi Fraternity Incorporated. On behalf of the chapter brotherhood, I welcome and thank you for attending our Omega Uplift Series number 8. Omega men are hard at work for our community. I want to first commend and thank the Social Action Committee for being true men of versatility. They have successfully met the demands associated with putting together numerous programs to ensure that the community is well informed on issues that have and continue to impact us. With diligence, they have created programs that have informed our community about the various vaccines being developed and deployed to address this global pandemic. The goal of these programs are to make sure that the communities we represent are informed about the positives and negatives associated with each vaccine's use. While leaving the decision to consume a vaccine to each individual, we firmly believe that knowledge is power. Our esteemed professionals and the expertise that they bring continues that discussion. It also shows that we support an informed community, and this information can positively impact their comfort with the intention to use the interventions developed. The Omega Psi-Phi Fraternity Incorporated was founded on the campus of Howard University 109 years ago. Since its founding, we have been guided by our 4 cardinal principles of manhood, scholarship, perseverance, and uplift. Omega has played and continues to play a vital role in the social and economic growth of our country. Through our efforts, we aim to enhance the lives of African Americans. As a fraternity, we operate under 10 nationally mandated programs, which are centralized around issues in our communities. And through these programs, Epsilon Iota chapter has been a staple in providing these services to the greater New Haven community for 30 years. Before we get started, I would like to share a few reminders. All participants will be muted during this presentation, but we do encourage your active participation by utilizing the chat feature. All questions will be acknowledged at the appropriate time by Brother Ruel Dixon. Before we begin, I again would like to thank our esteemed panelists for agreeing to participate and lend their expertise on this very important topic. Our series moderator today will be Brother Kevin Walton. Brother Walton plays a key role in Omega at a chapter, district, and international levels. He is no stranger to the greater New Haven community. He serves as head coach to the Wilbur Cross boys varsity basketball team and is the co-founder of Storytellers New Haven. He is a youth mentor and an exemplary New Haven leader where he advocates for all New Haven residents. We hope you enjoy our program. I will now turn it over to our Social Action Chairman and our Uplift Series moderator, Brother Kevin Walton.
Thank you, Brother Boslis, and good evening, everyone. Thanks for joining us. And Brother Boslis, thanks for trusting in me to take part in such an important conversation. We started this Uplift series in May of 2020 for the purpose of providing information about COVID and all the aspects of its impact on the Black community. This is our 8th community conversation, and we believe that it is the conversation that needs to be held at this time. In a year's time, over 400,000 people living in the United States have died from COVID. In Greater New Haven, over 450 people have succumbed. As the pandemic rages on, even introducing new strains and variants, some believe that we are rounding the corner as numbers go down, and having the vaccine available will help tremendously. At the same time, there are a lot of people in the Black community who are reluctant to get vaccinated. Per usual, our goal tonight is to provide as much information as possible to help our audience make the decision that is in their best interest about vaccination. The personal views of our panelists are just that, their personal views and opinions. However, I anticipate that there will be a lot of information you'll hear tonight will be based on science, experience, and medical expertise. But again, the reminder, the takeaway is for you to make your own decision. And with that, we will begin our program by allowing our panelists to briefly introduce themselves, and we'll get right into our program. And so first up is Dr. Gary Desir.
Well, good evening, everyone. And I wish to thank the Epsilon Iota chapter of Omega Psi-Phi for the invitation and for organizing this. So I'll give you a personal perspective on COVID and vaccine. And as you know, I'm professor of medicine at Yale. And my department, I chair the Department of Internal Medicine. And we, as the department, have provided care for almost all the patients admitted with COVID at Yale New Haven Hospital and St. Raphael Hospital. So we have a lot of experience and we've seen a lot of things. Give you some numbers. So far we've treated about 4,000 people at Yale, and about, and you mentioned the death, 450 people have died, and that's about right. So that means if you get admitted with COVID to the hospital, you have a 10% chance of dying. That's very, very high. If you look at the flu, for instance, it's about 1 to 2%. So we've learned a lot about COVID, how to treat it, how to manage it. Our outcomes are better. We have some medications that can make it better. But we believe that there are really two major things. One, long-term is the vaccine. But in the near term, and also for the long term, is how you protect yourself from even getting COVID without the vaccine or with the vaccine. And that, I think, is important now and will be important in the future, is the use of masks and social distancing and washing hands. So that has to continue. But the vaccine is actually something that in the medical community, we view as a really good development. There are a couple of reasons why people might be concerned about the vaccine. First of all, it was developed really, really quickly. So if you look at history, it usually takes 5 to 10 years to develop a new vaccine. This one took 9 months. So it was very quick. But I can tell you, as a scientist, I'm a physician scientist, the methods to develop it had been in use for a long time. So we actually understand how it works. But ultimately, though, the question is it effective? So it turns out to be highly effective, 95% effectiveness in the 2 vaccines currently approved in the US. One is by Pfizer, the other one is by Moderna. And ultimately, however, it's a personal decision whether you take it or not. In my own case, having seen what I see in the hospital, what COVID can do to a person, regardless of age. If you're older, it tends to be worse, but we've seen young people pass away. I think it's worth, in my opinion, is that both as a scientist, having read the literature that describes the vaccine, how it was developed and why it was approved, and the understanding the effectiveness of the vaccine and the potential risk, my net assessment is that it's worth taking the vaccine. So that's why I took it, and my family members have taken it, and my wife will be coming up and she can tell you about it. So so that would be my advice, but I'm happy to answer questions and entertain other opinions. So I'll stop here and let other people introduce themselves.
Great. Thank you, Dr. Gary Desir. And next up is Dr. Deborah Desir.
Sorry, one of my sons has made a t-shirt for family Zooms that says your mute is on, but I've got it off now, and I'm Dr. Deborah Desir, and I would like to thank the brothers of Epsilon Iota chapter for putting together this evening and for their outstanding work in the community. I am a clinical rheumatologist. I'm on the faculty at the Yale School of Medicine, but what I do in my daily work is take care of patients with rheumatic diseases. And I'm delighted to be here tonight because I think that our community, as everyone knows, is particularly hard hit by this worldwide pandemic. And it is a great opportunity to bring information about both COVID and the COVID vaccines. As my husband mentioned, we've both had the vaccine ourselves. I know that there are a number of concerns about how rapidly this vaccine was developed. And hopefully we can put your minds at ease about that. We have both taken it, and two of our four children have taken it because they're, one's a doctor and one's a medical student, which makes them frontline healthcare workers who needed to be vaccinated. So we would encourage everyone who's eligible to take the vaccine to get it. And we're happy to answer any questions and concerns about this. I take care of patients who are immunosuppressed. And so there are even more questions from my patients about, should I have this vaccine? Is it safe for me? And again, we're here tonight to answer any questions that you may have.
Great, thank you very much, Dr. Jazia. And then next up, we have Dr. Tamiko Jackson McArthur.
Good evening, everyone. I want to thank the brothers of Epsilon Iota for putting this together, and also for collaborating with the New Haven chapter of the Links Incorporated, specifically through our facet called the National Trends and Services. I just want to give a brief synopsis of what National Trends and Services is and why I thought it was such a great idea. The National Trends and Services facet is tasked with eliminating disparities by reducing barriers to resources through advocacy, education, and service. Our chapters are empowered to raise their voices and transform the communities in which we work. The facet's goal include increasing the number of sustainable and measurable programs, increasing collaborative partnerships, and extending our existing initiatives into our communities. So I work primarily in primary care, and one of my focus around COVID-19 is community education. I'm kind of, um, I'm kind of right there on the ground level. The parents come in asking generalized questions, and I feel that when our community is making decisions around whether they are going to take the COVID-19 vaccine, I want them to make it around a sound, basic knowledge of the vaccine. I'm not here to say you have to take it. I mean, I'm saying that you should take it. I took it. I got my second vaccine yesterday, so I finished the series and I'm still here. But my main focus is to provide an education around the COVID-19 vaccine in a very germane way so that people can understand it and not be so afraid of it. Our community has reasons to not have confidence in the medical community. We know that. But myself, Dr. Desir, and Dr. Desir and Reverend Ross Lee, we're here to try to dissuade the feelings that people have that are uneasy about the vaccine. So I'm here to answer any questions that I could.
Thank you, Dr. Jackson McArthur. And last and certainly not least, fourth is the Reverend Brother Samuel T. Ross Lee.
So, good evening. I need to make two corrections. One, I don't come on here as an expert in any of this. And the other correction, Sister Tamiko, I don't come here to advocate for the vaccine either. I want to thank the brothers of the Epsilon Iota chapter, Omega Psi Phi, my chapter, my fraternity, for asking me to come here and present reasons, I think I'm going to call it that there's a hesitation, and there has been hesitation in the Black community around this vaccine. And I compiled some information from various places. We all know about, Tuskegee. Some people think that it's ancient history. It is not ancient history in the African American community. Henrietta Lacks is not ancient history in the African American community. And there has been disparities around how African Americans have been treated in the medical profession. I found information from the AMA, articles around that issue from them, admitting and acknowledging that. I found articles from Harvard University. The one that I found most interesting, though, and I want to kind of read this, was from a doctor who is also a assistant professor of emergency medicine at the University of Pennsylvania. And the title of the article that she wrote says, I'm a Black doctor who didn't trust the COVID vaccine. Here's what changed my mind. So the article talks about why she didn't trust and what changed her mind. But I pulled this particular quote out of her article, and it says this: let's normalize hesitancy to take a new vaccine. Shaming people who have questions will not encourage uptake. Skepticism is especially salient for Black people, for whom centuries of mistreatment and harm from systems meant to serve and protect have engendered mistrust. I mentioned to the brothers some weeks ago, I was on my way to the church one Sunday, and I was listening to MSNBC, and Dr. Fauci was on one of the talk, shows they have there, and he said, rather arrogantly, I do believe, African Americans need to stop the hesitation and take the vaccine. And I was taken aback by that. I have respected what he has done so far and how he has stood up even to the president and that sort of thing. But I felt he was so out of his lane saying something like that. The community, medical community, especially, the white medical community, has not taken seriously in so many ways why African Americans are hesitant, and the specifics on how we have been treated in the medical community. So it's not a matter of, I haven't told my congregation whether to take the vaccine or not. I haven't told them whether I'm taking it or not. I'm leaving that up to individuals to decide. But if people are hesitant, it shouldn't be something that's dismissed, or they shouldn't be, no one should try to rush them into doing this. But we need to respect the fact that there's a history and there's a contemporary reality, and not just around the vaccine, but just in general of how African Americans have been treated in the medical community. I have my own experiences. We have the reality of Black women having disparity of Black women in terms of childbirth. Serena Williams and Beyonce being two of the most, obvious and visible cases around that. So yeah, that's just the reality in terms of how we have engaged, and we have been engaged by the medical community, and that is determining for some people whether they are wanting to take this vaccine or not. Also, because of the speed at which it was, brought about. I don't know how to say that. That it was fixed and made up is also a hesitation for African American people as well.
All right. So good. So thank you. So thank you all for those opening statements. And you all pretty much touched on some of the things that we're going to get into tonight. So so throughout this whole time, and they started talking about the vaccination, and Dr. Desir mentioned it, as Ross Lee did as well, and talk about the speed in which the vaccine was developed. And throughout my travels, I've heard people talk about that after years of research, there's no cure for HIV/AIDS or cancer. However, in less than a year, they have a COVID vaccine. So what? And I'll start with you, Dr. Gary Desir. So what do you say to those that have expressed concern that the development and approval of the vaccination was rushed through?
Well, I think that that the methods for developing vaccine have been in use for many years. What allowed this vaccine to be developed so quickly was that there were new methods being developed, and that we've used in research protocols for years, but they'd never been employed for the manufacturing of large-scale vaccines. So when this happened, companies were quick to put in place those new methods that have been in use for a while in the production, in the large-scale production of vaccines. So the methods have been used before, but never used in a very large scale. And I've taken a look at the clinical data. So the question then is, if you make a vaccine, is it effective? Is it safe? And Yale did participate in one of the early vaccine trials, it's Pfizer vaccine trial. But I've looked at the data from both Moderna and Pfizer. And the trials are very large. It's about 40, 50,000 people each. And the efficacy data is outstanding. And the side effects appear to be minimal, really minimal compared to other vaccines. Now, the one thing I would say is that those are short-term follow-ups. So we don't know, let's say 20 years from now, whether or not all of us who took the vaccine will, your left arm will fall off or something like that. It's very unlikely. But there is this risk that one has to recognize, that we don't have long-term follow-up for the vaccine. But so far it's about up to maybe about to 8 months follow-up. So far it looks great. About vaccine hesitancy, I have to say that I agree with the Reverend. So we had a professor from Harvard talk to us about what she calls medical apartheid. And she's written a book. Her name is Dr. Washington, Professor Washington from Harvard. And the book describes basically the history of medicine in the US in particular, and how it uses enslaved people to test things. And it is very clear why people don't trust the medical system. So one of the participants asked her, well, what should the health systems do to enhance vaccination rates? She said, well, it's very simple. All you have to do is to create a trustworthy health system. Now, she was being facetious because you can't just do that overnight. So it is understandable why people would be concerned about taking a vaccine from a health system that you can't trust from the beginning. On the other hand, I would say that look at who's taking the vaccine now. It's all the people who actually currently have to trust the system because the system works for us. So if you're Black and Hispanic and you don't take the vaccine while everybody else takes it, you're passing up the chance of getting something that everybody else is getting. So that's one way to look at it. But, and then you have to balance the risk of the vaccine, and there is always a risk to a new medication. That's undeniable. But what is the risk compared to the risk of not taking it? What is the risk of getting COVID? As I mentioned, if you get it, it's about 10% overall mortality if you get admitted. So that's what you have to take into account. And that's what I look at when I decide to take a medication or not.
I just want to sort of piggyback onto that, and I agree with the Reverend about the health system, especially the terrifying statistics about perinatal mortality, Black women in childbirth and immediately postpartum, and they're dying at alarming rates, regardless of socioeconomic status or insurance coverage. Because I know in the system, they like to say, well, maybe that patient didn't have insurance, or maybe that patient was in a socioeconomic group. But the two women you mentioned, Reverend, are two of the most powerful Black women in the country, and they almost died immediately postpartum. So I hear you, but I think this is a separate issue. And as Gary just pointed out, there are people, I used to joke, I'm not taking that until they test it on millions of people, or I'm not taking it till Fauci takes it. But the reality is that the groups that are well served by this system are fighting to get the vaccine. Some of them are offering their doctors $25,000, $50,000 to put them at the head of the line. They had to pass the governor of New York had to pass an edict where they will fine you or you will lose your license if you give the vaccine to somebody who pays you to get it ahead of the at-risk groups. So I think that that is something for people to really consider. They're not, for once, they're not taking people with no advocates to experiment on them. This is something that is well developed. The short-term risks are very, very, short-term side effects are very, very good. We don't know the long-term side effects because it hasn't been around a long time. COVID has been around longer, and we are starting to see, even in people who survive, fairly horrific long-term side effects in patients who don't do well, who have COVID. So long-term side effects will come with time, but
allow me something around what both doctors Desir's said here, because it's being repeated a lot. You know, there are other people who are taking it, and there are people across the country, and they're famous people, and you know, this sort of thing. But I think we need to have a more targeted conversation, because the persons who are unwilling and have hesitancy to taking it are not necessarily looking at what other people around the country are doing. They're considering the medical reality that they engage, you know, on a day-to-day basis or month to month or whatever, how many times they go to the doctor. And the conversation, I think, around whether their hesitancy is lifted, because, you know, you guys have a very different perspective. I mean, when I read the quote that I read, the article that from which that quote comes, she had a very, it was largely, the lion's share of what she said was very scientific in terms of what changed her mind. You know, how many, you know, one of the things that Dr. Gary Desir said around, you know, how long this process has been around, the vaccine making thing has been around. How many people were involved. She knew all of that information. She was even, you know, made more comfortable about the Black woman who was participating in it. But the average person on the street may not have, or may not, the synthesizing that kind of information to their personal reality may not be convincing still, because they're still dealing with the same medical system and the same medical people that they have always had to deal with. And so I think the argument to convince them has to be more targeted to their personal realities. I mean, not individual personal, but, you know, more, you know, bring it home, basically.
Thank you. Tamika, you want to jump on? Dr. Jackson McGrath, do you want to jump in?
Yes, and I kind of agree with Reverend Ross Lee around, but I think he's saying make it so that people can relate to it at a level that's not so so big. Kind of fine tune it so we to make folks understand. We know what your issue is. Let's talk about where you're coming from. Almost like meet them where they are. One of the things that you asked about with the HIV virus and the COVID-19 virus, folks are like, well, you don't have a vaccine for HIV. There are two different viruses that act so differently. You know, HIV is constantly changing. That's something, and I think Dr. Gary Desir, who is in the lab more than I am, could, you know, for folks who say, well, you don't have that vaccine, you almost can't, because the HIV vaccine changes so frequently. You would have to have so many different vaccines for it versus COVID-19 vaccine, which they learn is stable enough to make a vaccine. You know, what comes to your body as an infection is going to be almost the same almost all the time. So a vaccine is in order for that. And that's why we're able to do that. And also, it's not quite new science. While, specific vaccine for COVID-19 came so quickly, SARS has been around for a while. And I think this is all around that same research, if I'm not mistaken, that they've been looking at this for a long time. They just focused it on COVID-19. So it's almost like they were trucking along. They got to a point where, okay, generally it's a SARS vaccine, but now let's cater it to COVID-19. So they had a lot of work already done. Am I correct, Dr. Desir, Gary Desir?
Yes, you are. Yeah. So
Okay.
there was a lot of prior work on which they can base the vaccine development. And I don't want to go into the details of it, but as an example, just brief example, the sequence and the structure of the virus was determined in about a month. And that usually takes much longer than that. And that allowed people to make the vaccine much quicker. But let's go back to what the Reverend's saying. How do you meet people where they are? And I think this is the purpose of this meeting, I think, in that I think each person, each one of us has the opportunity to talk to somebody else and to try to reach them where exactly where they are. So this is a way of spreading the message. So you can be convinced this is a good idea, or if you want to do it, then you can convince others. And I think you're right. It is hard for me to know where any single person is at any particular time unless I have a conversation with them. And that's not what we can do in this particular forum.
But I think what you said, to just paraphrase what you said, was that if you are Black in this country, you have a higher risk of getting COVID-19. If you get COVID-19 and you are Black, you have a higher risk of not doing well. And if you get hospitalized with COVID-19 and you're Black, you have a greater risk of dying. Almost every person on this call knows more than one person who has died of COVID-19. They are not all old. And even if they're old, my grandkids love their grandmother. So even if they're old, we don't necessarily want to get rid of them. And everybody knows a young person who died of COVID-19. And if that's not reaching people where they are, I don't know what is. And that has nothing to do with the RNA sequence. It has nothing to do with how quickly the vaccine was developed. It has to do with the fact that the vaccine has a 95% chance of protecting you from getting COVID. And if you get COVID, after you get the vaccine, you will do better than if you don't get the vaccine.
Okay, so that's good information, because as someone who is up for the vaccination at my job, and I still haven't decided, so there's some reluctancy. I've been seeing a lot of Black medical professionals who are documenting their journey and encouraging people. But we've talked about the safety of the.
Can I just add one thing, and on that, people need to wear a mask, need to stop gathering in your homes in what you think are small, safe groups and pods until we get this under better control. I'm sorry to interrupt.
No worries. So listen, so can you all help the audience understand what the process for vaccination to get approved? So I heard you say that it's been in the works for a long time, but what's that process like to get a vaccination approved?
So the way it works is that, so let's take this for example. So the way it works is that you have to figure out a way for you first test it in animals. You let's say there are many ways of developing a vaccine. One is to take the protein, the virus itself, the protein it makes, and then inject it, and then make sure that animals can make antibodies against it. Or you can take a part of the vaccine, of the virus, and then make the body create the protein so you can make an antibody against it. And that takes a little bit of time in animal work. And then you create the vector for the vaccine, and then you do a clinical trial. So what happened in this particular case, when SARS-CoV-2 was discovered in January, they figured out how it works, and they made the vector for the protein, and they created a vaccine. They tested it in animals and seemed to work fine. And then they rushed to do a clinical trial, which is what you have to get people enrolled in trials, and you test the vaccine to see if it works or not. That's how all vaccines get approved. And there was a tremendous effort across the world to do that. There are trials in Russia, in China, in South Korea, in Europe, in England, and in the US. And the two vaccines that were approved and the trials were done in the US, one was Pfizer, which is a very large pharmaceutical company that is very experienced in vaccine development. So they make a lot of vaccines. And the other one was Moderna, which is a new company, but that has developed a new method of making vaccines. So those two companies were able to get significant funding. So usually what is the problem is that you don't have enough funds to do the trial. So they were able to get enough fundings, some of it from the government, to do a trial of 40 to 50,000 people, and the results were really great. So once you get the results, you submit them to the FDA, and the FDA has a panel of scientists and community representation, and they review the data, and they are looking at both efficacy and safety, and there is short-term safety and long-term safety. In this particular case, they accepted medium-term safety because of the pandemic was killing a lot of people. And based on these data, which you can look at, you can go to the FDA website and download the actual clinical trial data, and you can look at it. And the trials were very well carried out, and the results were good, and the safety data looked good. And so because of the pandemic, they provided what's called emergency use authorization, which means that it is approved for an emergency purpose, which is the pandemic. And that is the reason why, it's called an EUA. Because of an EUA, you can't mandate the vaccine because there is a certain potential long-term risk for it. So that's why it is not mandatory. And that's the development process. The development process is quick, but they didn't take any shortcuts on it.
Okay.
Yeah.
Right.
And I think the fundamental problem is that there is a certain mistrust of the health system, which is well deserved. I mean, the health system has done things that don't engender trust. And the problem we have is that this is the one time when you need everybody to trust the health system. Mm-hmm. And you can't do it overnight. And that's the problem. So one has to make you have to decide for yourself. Do you have one set of risks, you have the other set of risks, and you have your own perspective. And I think that's what you have to discuss with people one-on-one, and you can't do it in a mass production.
Got it. Okay. Tamika, Dr. Jackson, I saw you shaking your head. You want to respond?
I didn't know that the emergency use precluded making the vaccine, making you have to have it. I didn't know that. That's something that I just learned, and I was thinking that at some point, the COVID-19 vaccine may become obligatory in some situations. There may be some with traveling, going to school, certain situations where they're not going to want to risk getting an index case, because we know that while the vaccine is holding for the different strains, the virus is extremely smart, and it's making itself a lot more contagious. And one of the things that I really want the community to understand is and I say this is just a very simple way of explaining this, that if you have COVID, if you had the old COVID-19 virus and you infected the person in front of you, that one person, then that person infected someone in front of them, and then that other person infected someone in front of them. But now that we have the different strains from other places, the simplified hypothetical is that that one person infects 50 people now. Those 50 people now infect 50 people. Each person infects 50 people. You see that exponential spread? And we need to understand that, we do have those cases in New Haven. And one of the things that, as Dr. Deborah Desir said, we cannot, one, let up on mask wearing. They are saying 2 masks, if you can handle it. I think mask wearing, for me and for people that wear it like 12 hours a day, it's like second nature at this point. I wear 2 masks, but it's very hard to do for long periods of time. But it's very important that, because of the way the virus is changing, whether you get the vaccine or not, because I'm vaccinated, but I still need to protect myself. You need to wear a mask, you need to wash your hands, and we need to stop gathering. And one of the things I've been saying from the beginning is that I cannot disinfect someone's lungs. The fact that I'm having a dinner party and I have 5 people coming over, oh, I know them, they're clean, and I'm doing COVID cleaning. What is that? You can't clean someone's lungs from COVID-19. If someone has it and they're asymptomatic, I don't care how much bleach you spray in your house. When they come to your house and you talk to them, if you remove your mask, you're at risk for contracting COVID-19. We have to be we have to understand that as a community, that our gatherings are, the small gatherings, what really are seeding the community. And I know it's hard. I mean, personally, I haven't seen some of my family since this started, except through Zoom. And it's very, very hard. It's emotional, it's emotionally draining. There's COVID fatigue. There have been papers of how this is affecting my pediatric population. But we have to understand the risk, and keep wearing our masks, keep protecting ourselves from believe it or not, our friends and some of our family members. We can't gather. So one of the important things that, as a community physician, is my education piece is prevention. So I teach prevention, or I promote prevention in anything and everything. And with COVID-19, all of us on this webinar and our friends and family, we should impress upon each other prevention with COVID-19. We don't want anyone who doesn't have to go through having the infection to get it. We should do all that we can.
Yeah.
Thank you. So I think what we'll do right now, because our audience is putting some questions in the chat, and we thank you all for joining us, and thank you for your questions. So Brother Dixon, you want to read the first question?
Yes. So the first question I have, and is 2 parts. Has the transmission rate increased now that schools are open? And what are the studies saying in terms of vaccinating children under 16?
I think the first question is hard to answer. The number of cases has increased, but I don't believe it's through. There is no evidence that it is through schools. Because schools are open. The evidence is that there is a lot of what's called community spread, in that people who have COVID and are asymptomatic, they don't actually know they have it, and they meet with other people and they infect family members and friends and things like that. So I think I can't say it's increased because of school. I'm sorry, what was the second part of the question?
What is the research saying in regards to vaccinating children under 16?
Right. So the EUA, I believe, is not for children under 16. So currently there is no plan to vaccinate children under 16. The issue of the EUA is that a organization, let's say the school, can decide, in general, could decide that you have to be vaccinated to come to school. We do that for certain diseases. But because it's an EUA, there is no plan currently to actually mandate vaccination.
And can you explain what an EUA is?
It's called emergency use authorization. So the So the FDA gives different kinds of authorization, and under emergency use, there are certain things you can't do. You can't, as an example, I don't believe you can mandate it, and that's why many places have not mandated it. if it gets full authorization, then schools could actually mandate vaccine. And we do that for certain diseases.
Could I just say, for the Pfizer vaccine, it's 16 and up. For Moderna, it's 18 and up. And a word about the schools as we talk about the Black community. There are reports that if schools open properly, you don't see an increase in spread. And it is astounding to me, and it's going to have huge manifestations for our children, that 78% of private schools are open for full face-to-face learning and only 36% of public schools are. So again, and yet another socioeconomic issue.
Right.
Absolutely. And that you make a great point, because we talk about kids, our kids, especially Black kids and Latino kids in the inner cities are going to be a year or two behind, and that achievement gap is going to widen even more. So, and that's been a lot of talk lately too, around teachers demanding to be vaccinated before they go back into the classroom. And maybe we can discuss that more down the line. But I'd like to give everyone, Ross Lee or Dr. Jackson McArthur, opportunity to chime in on that question.
About the openings of the schools?
Yeah.
Well, I don't know much about that actually. My daughter's out of school. So I don't know what's going on with that reality. I do know that if she were still in school, that she wouldn't be going because she does have a underlying condition. She has asthma. I don't think I would be comfortable with her being in that setting.
Okay. And I know, Dr. Jackson McArthur, that this thing has been near and dear to your heart. So I don't know if you want to chime in at all.
We know that this is not the best way to educate our children, especially our Black and brown children in the urban communities. And we have to find the best route to educate them. We know that when schools are closed, their food is interrupted. Their schools are safe havens. So we need to make sure that when we open, we are opening with the safest of possibilities. We know nothing's going to be perfect. We know that. We just have to, check those boxes. I can't say much more.
We got you. We understand. Those that know, right? All right. So thank you. So, Brother Dixon, you want to go to Craig Streeter's question?
Yes. Can the clinician speak to the vaccination protocols for people who have already had the COVID-19 virus?
Sure. So the recommendations are, if you have had COVID, you are probably protected for the next 90 days, next 3 months. But then if you can get vaccinated, the recommendations are you can get vaccinated 4 weeks after you've recovered from after you've had COVID. So you can get vaccinated 4 weeks later, or you can wait 3 months and get vaccinated. So that's the protocol we're using currently with our healthcare providers who have had COVID, and they still get vaccinated within 4 weeks of having had it.
And I think it's important to know that because I've had people say, well, I had it already, I'm fine. And then they just go about their life. This isn't normal. You just can't go about your life. You can't just go about your life. If you've had COVID and you have fought COVID and you're back into mainstream, you still need to protect yourself, because you can still infect other people. If you contract it again, you could still, COVID situation that we're in right now, we're going to be wearing masks for a long time. Even vaccinated people, if you've had it, you still can't just go back in the mainstream and just live your life. That's not going to happen. I think that's a very important point to make. Vaccinated folks and folks that have contracted COVID-19 still need to wear masks and have the precautions that we're talking about this evening.
Okay. All right, great. Thank you. So so I'm gonna direct this next question to Reverend Ross Lee. And everyone, he'll go first and everyone can chime in. My question would be, how much does racism and historical mistrust of the medical field play in our reluctance to take the vaccine? So I know we've talked about Black people and our kind of skepticism, but what about speak a little more to the racism that plays into this reluctance?
Right. Yeah. So much of what I read when I was preparing for this spoke to that. The racism. There are, there's still doctors out there who have, different understandings or different thoughts or different ideas about, how Black people can endure pain, more than white people, and how you look. I remember a few years back, I had a kidney stone. Hurts. Everybody knows that if you've ever been there. I was taken to the hospital, actually by one of my deacons. I called an ambulance, but he showed up first. When I went there, I was in sweatpants, a t-shirt, whatever. I don't have my degrees or ordination papers wrapped around my neck, to show who I am or whatever. So I come in there and I'm just a Black person, right? They don't know anything about me, and the nurse in the emergency room was just very dismissive, very disrespectful. They checked my insurance at least 3 or 4 times, which it was cute. I understand what that was all about, and I was in so much pain that I couldn't muster enough energy or strength or focus to say anything to her until I was about to leave, when the pain had subsided with whatever they had done. I don't actually remember. And I was at Yale New Haven, and I said to her, I said, I think I'm going to talk to the CEO here. I know her, and I think when I use the pronoun her, it she kind of perked up because she realized that I may actually know this person. But yeah, I think racism plays a great deal of around the hesitancy and how people have been treated, and how they have been dismissed. The doctor who was in the hospital for COVID, talked about how she was being dismissed and how she's being treated, and how she had to beg for painkillers and this sort of thing. And then the response after she passed away, the information came out in the newspaper thing. One of the I don't remember what his position was. He was, one of the head people. He said something about the persons who were working with her felt intimidated by her. And I was like, do they realize how white that sounds? How, they're sounding right now by saying that they felt intimidated by her. What was intimidating by her? That she knew that she was a trained physician, and she knew what was going on. She knew what was supposed to happen, and she was insisting upon it because you wouldn't help her, or her being Black made her intimidating, and they had the audacity to put that in the paper as their reason for how they treated the situation. They felt intimidated by her. It's like, what Black person hasn't heard that before? And so I think racism plays a great deal in how the medical community has treated Black people and how Black people are reacting now.
Yeah, and I think Reverend was referring to the woman in Indiana who said those things, and she documented her treatment in the hospital. And so Dr. Debbie Desir, as a Black woman and as a doctor, what was your reaction to that story with that with your colleague in Indiana?
I think I was rendered, it was just sadness, and also understanding what she experienced, because I'm a Black woman in America If I go to an emergency room, I'm just an elderly Black woman. Unless I go to Yale and then I'm Gary Désir's wife, but that's a whole different story. But I see this every day. My sister lives in this community, and she went to the emergency room, and she said that the difference in how they treated her was palpable when they found out she was Gary Désir's sister-in-law, because before that she was. And we had a long conversation about this at rheumatology rounds, and it was a talk on race in medicine, or how you deal with race in medicine, and it was very, the problem is that when some people in the profession see us, they don't think this could be my mother, this could be my sister, this could be my father. They just see, they saw you come in, Reverend, and you had your sweatpants on, and they said, oh, he probably just wants pain meds.
Right.
And that's what we dealing with the medical community all the time. And I think that's what makes people so skeptical about care. And I'm not saying that every physician who is Black is wonderful, and I'm not saying that every physician who is white can't get past their implicit bias to take care of patients. I'm not saying that at all, but I do think it's a huge problem. It's my own mother, who we moved to Connecticut when after she had a stroke, and my sister took her to the Yale emergency room in Guilford, and they told her, well, you have Medicaid. Well, my mother didn't have Medicaid. She had Medicare and a perfectly good secondary. And they asked my sister 3 or 4 times, well, she has Medicaid. And first of all, what difference does that make? But secondly, she told her no, she produced her cards, and they still wrote in her chart that she had Medicaid. They could not see beyond this, she's an elderly Black woman, she must have Medicaid. And this is what we deal with. It's exhausting.
Absolutely.
It's exhausting. And everybody doesn't have advocates. But even my daughter, who is a medical student, my youngest child is a medical student, and she said it's remarkable that she went to college in Boston. The care she got in an emergency room there is so different than the care she gets at Yale, because at Yale she's Gary Désir's daughter. So
yeah.
Well, I think it was heartbreaking to me to hear that woman, to hear her reading her recording, the events that led up, and she didn't even feel comfortable going back to that same hospital.
Right.
She had to go to a different hospital in an attempt to
Yes,
care. And they were intimidated. They still let her die. So how intimidated were they? They weren't intimidated enough to deliver the care she needed.
Right. Absolutely.
Can I make a comment?
Sure.
Because of those, implicit, what we call implicit bias, and very often explicit bias and racism, we try to mitigate those things by developing treatment protocol. For COVID, for instance, when the pandemic began, we were aware that this could happen. So whoever comes to the ER, emergency room, might be treated differently, whether you're Black or white or something else. So we developed a treatment protocol where it was accepted by the health system. So everybody who came to the ER, there was a certain protocol you had to follow, whether you're white, Black, or not. And I think that helped. That helped for this particular pandemic. But it is a daily occurrence that there are people make assumptions on who you are, depending on what you look like, and those assumptions drive what kind of care you get and what outcomes they achieve. And it's something that we have to work toward. We're not going to fix it overnight. I would want to say, though, that don't let those things keep you from getting care that you might need, regardless of, and I think that's the way I would think about it. Here is an example of where everybody else is rushing to get the vaccine, and we're not. So you have to think about that. So do they know something you don't, or do we know something they don't? And I would submit that this is the one time when I would say, maybe take a leap of faith that the system has your best interest in mind. even though it hasn't been always that way.
And I know you guys are going to think I'm biased, but Gary kind of glossed over something right there. That is the fact that they were able to institute that policy where people get the same treatment. We need people like Gary in the position he's in, so that we can get taken care of, so that everybody can get taken care of. And it's not a small, that is not a small thing.
Yeah, and thank you for that, because I want to get to Dr. Jackson McArthur, but I was going to ask you, Dr. Gary Desir, well, you just told us, right? But was that something that you developed?
So yeah, so we have a team. Our team developed it. The Department of Medicine. We established a small group of people, about 12 people, who are expert in their field, infectious disease, pulmonary disease, and they developed a management protocol that's codified, that we publish and that we incorporate in the electric health record, and that everybody accepted as the standard protocol. So everybody who comes in gets the same protocol. We actually have put the protocol on social media, and it's been downloaded probably 200,000 times. So, and we've updated it. Whenever there is a new change in management or therapy, we update it, and we give the reasons why we update it. And I think it's been really good in minimizing, not completely eliminating, but minimizing implicit bias and differential treatment based on who you are.
And I think that's, well, my first question, is it copyrighted, right? You know, because we could talk afterwards. But secondly, I think it speaks directly to why we need people of color in those positions, because I imagine you come from a position of understanding the treatment that we get historically. And so I just wanted to point that out, the importance of having people of color in positions of power to make those type of decisions. And what's not lost there is the fact that when you make that better for Black people and disenfranchised people who feel disenfranchised, it makes it better for everyone, and the system becomes better. Right. So good, that's wonderful. And so thanks for your patience, Dr. Jackson McArthur. But just kind of the same, if you want to touch on anything that was said in this segment here.
Yeah, I think this was a perfect segment for tonight. And I have to say, like Dr. Deborah Desir, we should be thankful and appreciative. We do have some really strong advocates in powerful upper echelon of the hospital, and Dr. Gary Desir is one of them. True advocate for the people, and he's not the only one there, and that's a good thing. Just by especially what he said about the treatment for COVID-19. I'm sure that's not the only protocol he has in place to help bridging that inequity we have with treatment. But I have to say that we do face a lot of bias outside of, I would say, like our comfortable zones with the medical profession, seeking medical care. As I said earlier, my thing is advocacy. I advocate for my patients all over the place. I've experienced racism in the emergency room myself, my patients, and my advocacy goes so deep that I had an attending ask me, because I called to tell them something wasn't right in the treatment of a patient that called me hysterical. And they said, well, why do you always call? You're so angry. And that I was, and you know what? And then I got angry and I had to go off. So when I call the ER many times now, they're like, oh, New Haven Pediatric, Dr. Jackson. They get on that phone and there's no crap because they know that I will call them on it. One of the issues is that we don't have enough younger doctors coming up that can relate to the people in our city, or the urban dwellers that come to the ER. We understand we use certain demographics use the ER a little bit more than others, and that sometimes is viewed as, oh, that's that Medicaid population, they overuse the ER. That could be right in some cases, but when someone shows up at your door for care, you should just treat them. You shouldn't care what if they're black or white or purple or brown. You should just treat them. You shouldn't use DCF as a weapon of mass destruction, which is what they do to black people. I mean, I've had patients where someone of the other persuasion may be taking a certain type of drug and their kid goes home with them. Someone looks like me might take marijuana and their kid goes into foster care. So there are a lot of reasons and a lot of disparities on how we are treated, and that is why we are so suspicious of medical advice, medical interventions, medical diagnostics, and it's an uphill battle for us all. Everyone on this call who is an advocate for their people, it's an uphill battle because we keep getting the same treatment over and over. And it doesn't matter if you're Gary Desir's wife, because if you go in and they don't know you're Gary Desir's wife, you're a little short, cute black lady. They don't care about that. My daughter was in respiratory distress in the ER, and they threatened to call the security on me because I refused to allow her to sit in the ER with shortness of breath with influenza last year. And so we just have to do better. And we have people like Dr. Desir in place to help us with this. I think, Yale has made great strides in putting Black people in places that they could help us make a difference. So I think, long story short, advocacy is the key. Don't be afraid to advocate. I'm never afraid to advocate for my patients or anyone who asks for my 2 cents. It's advocacy, advocacy, advocacy.
Thank you. So I think also Reverend Ross Lee mentioned earlier the article about the Black doctor who finally took the vaccination. And I read that same article. I think her name was Dr. Eugenia. And one of the things that came up in that, and I just want to put in a question form, is how do we respond to the statement that we need to empower trusted messengers to answer questions and dispel the myths of the vaccine? So we did that. We just had a nice conversation about that. But how, what's this whole issue, right? Because, I know there's one of our fraternity brothers is doing a video documentary of he's a medical doctor and he received the vaccine and he's giving an update and he's encouraging people. And so how do we speak to the statement that we need to empower trusted messengers to answer questions and dispel the myths of vaccines?
We can't be afraid to silence stuff that's not true and say when something's not true, that's not true. Let's go find the right answer. There are some things out there, like I'm going to throw out there. Someone said that they're going to inject me with HIV. There is that belief. I mean, I had to shut that down. We have to shut down nonsense because what it does, it like I said, it makes that hill just steeper and steeper and steeper for us. And don't be afraid to say, hey, brother, hey, sister, where did you read that? Because I haven't read that. And that's what I said. I haven't read that. Where'd you read that? Is that from someone who's a scientist or is that from someone who knows what they're talking about? Because I didn't hear that. And we can't be afraid to do that. Don't entertain things that aren't true. It does nothing for our community. It does nothing for the community at whole. Shut stuff down that's not true and don't propagate it. If it's not true, don't repeat it. That's one of the issues with this that we're facing.
So yes, I mean, I think that I think the question is, how do you engage in conversation with people and you are able to make them, let's assume they believe this is the right decision to take the vaccine. How are you able to make them, to help them make that decision? And I think it's easier the closer you are to the person. So, I mean, I can give you my scientific opinion. I can tell you what I did, but I can't go talk to, 100 people and convince them this is the right thing to do. So it's got to be, we got to scale up the work. So I'm happy to, I talk to a group like this and other groups, and then hopefully some of you will be convinced, and then you can talk to others, and then and then scale it up that way. But I'm always happy to tell people what I believe and how I made the decision that I made and what I see, because I've seen a lot of things and I know how things work. So I hope that my being here and my wife's and Dr. Jackson MacArthur being here would convince some of you to advocate and to whatever you believe is true, to be advocates for the vaccine. But I do realize that ultimately what we need to do is to make the health system more trustworthy. And unfortunately, we don't have time for that now. You know, we have a pandemic. We will continue to work on that. I'll do whatever I can to make it to hardwire trust mechanisms into the health system. The management protocol is such a way to do it. And there are other things like, you know, when do you decide somebody is do not resuscitate? How do you allocate resources? But I think ultimately one has to make a decision for yourself and then try to convince your family members and your friends. And that's really the only way we can do it. We can spread the message across.
Yeah, Brother Walton, I was going to say something very similar to that. I think the persons that you talk to, the medical profession persons that you talk to, need to be people that are close to you in some way, that you know, either as, you know, in their profession, they're your doctors, or they're friends, they're people in the community, they're people who go to your churches, and that sort of thing. The closer the professional is to the persons they're talking to, the more, I think, convincing it will be to the persons who have, you know, hesitancy around this. The doctor is actually named Eugenia South. That was her. That's her name. But yeah, I think you got to get people who are, you know, as much as possible, people who know people. But I do want to say this as well. What I hope that we don't do in this situation, because we've done it so much in this country, that you know, the government comes out, you know, for some past you know, sin against African Americans in a particular kind of way, because racism is still alive and well, and they, you know, they make some official statement, you know, official apology, no reparations, no anything except, you know, the statement, we apologize. I hope at the end of this situation, everybody doesn't just take a big sigh and walk away. One of the possibilities with COVID is that we have the opportunity to look at what's happening, because this is not just, if Black people are hesitant to take the vaccine, it's not just going to affect them. It's going to affect communities. It's going to affect other people where they're around. So it's not going to be contained within the Black community. It's going to be wherever those Black people are. This should be a time when we look at this situation and say, okay, racism has hurt the country, not just Black people, it's hurting the whole country around this situation. Now we need to look at the situation and say, what can we do? What steps can we take as a medical community, and use the vaccine, use COVID-19 as motivation, because the things that have happened to African-American people, that have made African-American people hesitant, is now hurting the country.
Okay, yeah. Dr. Desir, did you want to chime in, or are we ready to move on?
Can I say something?
Sure.
I would like to encourage people to, you know, if you have a good relationship with your primary care doctor, talk to your primary care doctor also. Your primary care doctor knows you, knows your underlying conditions, knows, you know, knows how to address getting the vaccine for yourself. So your primary care doctor could be a good resource for you to start the conversation around, should you get the vaccine or not, or why should you take the vaccine?
I know
Okay.
one thing I do is I talk to people who I presume trust me. And that would be my patients, my sorority sisters, my links, if I assume they trust me, my link sisters. And because people who start out from not trusting you, you're not going to be able to get anywhere with your So I try to be an influencer of the people who trust me.
Right.
And I hear you all saying that you'll talk to people and people that trust you. So would the suggestion be to our audience, if there is some hesitancy or some reluctancy, to seek out someone they trust, such as a medical professional or just anyone that they trust who will help them make that decision?
Yes.
Yeah, I think that's a good way of thinking about it.
Okay, great, thank you. All right,
But
we do.
this would-
Yeah, go ahead.
Remember the words of Ronald Reagan: trust but verify.
Trust but verify. Okay. All right, so let's speak a little bit about, because we talked about what it's going to take and doing some advocacy and acknowledging that there is a reason to be reluctant. But let's talk a little bit about what happens if I get this vaccine. So are there, and if there are, what are the known side effects of the vaccine?
So there are some people who are allergic, who would be allergic to the vaccine, and it's hard to predict who that be. So in our experience so far, we've had maybe out of 20,000 vaccinations, maybe 10 people develop some allergic reaction for which they need treatment. That's not a long-term problem, but it does happen. So far, we have not seen anything long-term, any long-term side effects, and neither was any reported among the 2 trials that have been published. You can find them on the FDA website. So long-term side effects are not, there are none so far that we know of. That doesn't mean there won't be any, because the more people you vaccinate, the more likely somebody will have a side effect. But so far, it seems to be very safe. There are some short-term things that happen, particularly with the second dose of the vaccine. And the first dose seems to be fine. The second dose, you get a reaction, you get muscle pain and sometimes fever, but they're short-lived, and that's an expected reaction. But otherwise, it appears to be a very safe vaccine so far, very safe.
Can I make a very important point about vaccines in general? There are two types of vaccines in general. One is what's called a live attenuated vaccine. That's a vaccine that is the actual disease that's been made weaker, and the other ones are not that. For example, people will tell you they got the flu vaccine and then they got the flu. That is not possible. I can't make a stronger statement than that. You can't get the flu vaccine from the flu vaccine because it's not a live virus vaccine. The 2 vaccines that currently have the emergency use authorization are mRNA vaccines. They are not the virus. You cannot get the Rona from the vaccine. So there's some things that people are concerned about that you're never going to convince them that's not the case, but you cannot get the disease from this vaccine, and you can't get the flu from the flu vaccine.
So, Dr. G, could you repeat that part about, because that's one of the things you hear, that they're saying that they're injecting you with corona with COVID. So can you repeat that part again?
No, they are not in, as I said, there's 2 types of vaccines. There's live attenuated vaccine. Everybody's heard of shingles. The original shingles vaccine was a live virus. And so I have to tell my patients on the medicines we give, you can't have that vaccine because it's just a weaker version of the live virus. There is a new shingles vaccine out that is not a live virus, and my patients can have it. And the same thing with this. This is not the virus. It's not even DNA. It's something called messenger RNA, which is DNA makes RNA, and RNA tells your body to make certain proteins. I might have to turn this part of the conversation back over to the other Dr. Desir, but you cannot, it is not possible to get the flu from the flu vaccine. It is not possible to get corona from the COVID-19 vaccine. And I cannot say that strongly enough. So of all the concerns that people might have about getting the vaccine, getting the disease should not be one of them.
So just a little bit more information. So this, and I think Mike Charles asked the question, how is this vaccine different from other vaccines? In this particular vaccine, viruses have proteins around them that's like a small cell. And then the vaccine, the two vaccines that have been developed is specific for one protein on the envelope that forms the virus. And it's called the S protein. And what they've done is to take the sequence of the S protein, part of it, and put it in, it's an mRNA, and then put it in a vector. And that vector is what the vaccine is. So when it's injected into you, your body makes antibodies against just the S protein. There is no virus in it, it's just a protein sequence. So there is no way you get COVID from the vaccine. And it's very specific. It's a very small amount of the virus. So it's a very safe vaccine from that standpoint. The other thing about it is that it does not use it doesn't use another virus to infect your cells. So many other vaccines use what's called the adenovirus vector. This one does not. So it's safer than the adenovirus vector-based vaccines. So it's actually a very safe method of making a vaccine.
Okay, great. I think that's
And one more thing, it
Yes,
doesn't change. It doesn't change your genes. It doesn't incorporate into your genetic material.
so you're not going to grow another head?
You're not.
No.
So Dr. Desir, could you touch upon the reaction on the second shot so people can understand what that is?
Yeah. So the first shot.
You're freezing. I don't know if you're freezing, but I think with the second shot, actually people who've already had COVID and with the first may see this with the first shot, but you're just going to get a sorer arm, more fatigue, maybe more muscle aches that lasts for about a day.
Yeah.
Okay.
With the second reaction, which is
That's the second. So the first reaction is the first time you get exposed to the sequence, you make antibody, you react against it. And then the second shot, you already been exposed to the protein and you see it again, and your body reacts much quicker. And it reacts much more strongly because it's seen this before, and your immune system revs up very rapidly. So that's why you get pain and chills and you feel tired because you've seen this before, you're trying to fight it. And that's the idea behind the second dose side effects.
All right, great, thank you. So in the chat, Dr. Desir said that Pfizer, Moderna are the only ones available right now. And David Brother Cockrell has a question, and it's, do you recommend one vaccine opposed to the other, and if so, why?
So they are equally effective, and they are the same method. So there is no difference. There are no observed differences between the two vaccines so far. So I have no basis for recommendation one or the other.
The reason why I said either one to my answer in the chat is that you're probably not going to have a choice because it's whatever, because of the fantastic rollout of the Trump administration for getting this vaccine to places, you're only going to be able to get whatever is there.
Available.
And so the first week, Yale had Pfizer, and then when Gary and I went, they had Moderna, so that's what we got. I've run into one person where their institution had both, but I think that one's 95% effective, the other one is 94.1% effective. So that's the same to me.
So the message is, if you go to get vaccinated, don't go in there asking for one or the other, just take what they're giving.
No.
Yeah, whatever they have, they'll give you.
Oh, okay, whatever they have. All right, great.
It is not Burger King, okay? It's not Burger King.
Have it your way, huh? All right. So So Brother Charles he asked, what's the difference between the new technology and previous? If I got that right.
Yeah, so I tried to answer Brother Charles' question. Previously, what you had to do is to, let's say you take the virus and you inactivate it. So, and then you inject it. And that's the vaccine. Sometimes you would take the sequence of the vaccine and then put it in a viral vector. Adenovirus is one vector that we use. And then you insert that. That one gets incorporated in your cells, in your DNA, and then it makes the antibody. This one just uses what's called messenger RNA. It's not a DNA-based vaccine. It does not incorporate into cells, and then it makes a protein. Your body makes a protein, then it disappears. So it's a simpler, quicker, and probably more effective way of making a vaccine.
Okay, great. I see. All right. So I have a question. I'm going to ask this if we can switch back a little bit. Then I'll get back to the chats. So, and I want to address this to Reverend Ross Lee, because we've had this conversation as a committee, and people offering, when we talk about mistrust in the medical profession, and especially around a vaccine or the flu shot, we often reference the Tuskegee experiment for not trusting the medical profession and vaccination. So, Brother Rossley, have you heard anything tonight that would help offset that conversation?
Oh yes, I've heard a lot tonight that would offset that. But I'm not the audience in regards to that. I'm not the one who is questioning in those ways. So, as we, agreed upon and understand that I'm coming to represent a hesitance that exists in the community. So I can't really answer to the extent, to what extent other people are still hesitant, even based on these conversations tonight. Because, like I tried to say at the very beginning, obviously the Tuskegee thing is a big thing in our consciousness, iconic in a bad way in history of African American people, but there's also the contemporary realities as well. And, I think, if people listen to this, you can change some minds. I definitely believe that. I think the doctors who are here are representing in a very credible way, a very authentic way, a very sympathetic way, even in terms of what has happened and what is happening to African Americans in the medical profession. And I think those things, more than anything else, will help people to overcome their hesitancy. It's the denial and the get over it kind of attitude that is going to make people say, no, I'm not going to get over it. And I'm not, just going to act like it didn't happen and it doesn't happen. That's the wrong approach. And that's why I mentioned Dr. Fauci, very credible in what he's done and what he's doing, but he was just so completely wrong in saying that, just get over it and go take the vaccine. That's not going to move people.
And I asked that because so much of the conversation was centered around speaking to trusted members of the community, and as a prominent religious leader, prominent leader in the community, I imagine that you may have that conversation once or twice with people, and not necessarily your congregation, but just people in general.
Personally, I've been more. I'm more of a reader, and so I've found information. I read information, that sort of thing. I know Dr. Jackson MacArthur. I'm stumbling over saying that because I just call her Tamiko. So I know Tamiko, and I don't think that she would bring two persons to this conversation whom she doesn't trust. And, outside of the things that I said about them in terms of how they've represented here today, I would trust them because she trusts them. I think, and that's what I mean by, pulling people in who are trusted. But then sometimes it will be, 2-3 degrees of separation. They have represented here very well. I think they can convince some people with the way they represent it, with the acknowledgement of, what has happened and what is happening. But, even if they hadn't done that, I would trust them because Tamiko trusts them. I mean, unless they just went,
Yeah.
it just went totally right, left field with what they were saying. I get the combination of those two things make me trust them very well and very much.
Well, I will say that I'm almost there. So maybe within, we got 25 minutes left, doctors. So let's go back to the chat.
Really quickly.
Oh, I'm sorry. Yes, of course.
I just want to say something really quickly, piggyback on Reverend Ross Lee's comment. I look up to these two doctors, Desir. I look up to them and what they represent in our community and what they willingly give to their community. And I send patients to Dr. Deborah Desir who come back, doing a lot better than what they've done somewhere else. And you could pick up any journal that talks about advancement in medical anything, and Gary Desir might be in there. These two people are pioneers, and I look up to them. And I actually was like, oh please, I hope they will come, because I know they have so much to offer. So I just wanted to say that I look up to them. So that's that.
We appreciate you,
Thank you.
having it. So, Dr. Deborah, I think you were going to say something?
I just wanted to say I'm so comfortable with this group. I think I'm among friends and people who know me, but I just wanted to be 100% clear. I was being sarcastic about the excellent rollout of the vaccine by the Trump administration. I didn't want anybody to think I was a Trump supporter.
Duly noted, because I think a lot of us on this call that I know speak sarcasm very fluently, so we understood that.
And many thanks to you for inviting us tonight. It was
this is great. So I'll get back to the chat real quick. And it's from the iPhone. How will the vaccine affect you if your immune system is compromised due to chemotherapy treatments?
So this is something that comes up actually in our practice every single day, because our patients are almost by definition immunocompromised. And by that, I mean our inflammatory patients, not our the osteoarthritis ones, maybe not so much. And the current recommendation is that immunocompromised patients should get the vaccine, because they're at greater risk from not doing well if they get the disease. So
Okay.
we are freely advising our patients to go ahead and get the vaccine. And we're expecting them to be in the next, right now it's frontline healthcare workers and people over 75 in Connecticut. Why on earth that does not include teachers, I do not know, because if anybody's frontline, it's teachers. But for immunocompromised patients, the current recommendations of, well, the American College of Rheumatology has not yet put out its statement. We're expecting it literally in the next few days. But the oncologists are encouraging their patients to be vaccinated.
Great.
If they get it.
Thank you. Someone else, or we can move on? Oh, okay. I have another question.
We need to hear that, because there are a lot of folks with rheumatological diseases that are asking these questions, because there's a lot of different thoughts. So it's good to know that they're going to be coming out with their opinions soon.
Yeah.
I think what engenders some of the mistrust is that the information is changing almost daily. And that's because it's brand new, and we learn something new every day. And sometimes things we thought were right turn out to be wrong, and we have to change that. So I think that doesn't necessarily build trust if the story keeps changing, but the reality is the story keeps changing because it's new and we're learning something every day. We initially were terrified that our patients were not going to do well. They're doing okay with, they're not doing as badly as we thought they would do if they actually contracted COVID. And, but we still recommend that vaccination for our patients.
Excellent, excellent, excellent. So Craig Streeter asks, speaking of other vaccinations, how should someone space out getting flu, COVID-19, and shingles vaccinations, for instance? But I hope he's not saying space out getting flu, COVID, and shingles. So I think he's talking about the vaccination.
Yeah, right. Yeah. Well, I would say that that you probably, and I don't know what the FDA recommends. I haven't looked at that particular question, but I would say, thinking about it, there is a specific sequence of getting the COVID vaccine. One is 3 weeks apart, the other one is 4 weeks apart. And I would say, don't schedule a flu vaccination during that time or shingles. I think the most urgent thing you can do if you're going to get vaccinated is COVID vaccination, because the amount of flu currently in the population is very, very small. And the reason it's small is because people have been wearing masks. So we're not seeing flu at all. So the chances of somebody getting COVID is much, much higher, like hundreds-fold higher than getting the flu. So if you did not get vaccinated in November, October, November, and December, and you scheduled to get vaccinated for COVID, I would get the COVID vaccine first.
Okay, thank you. Rosalind asks, are you truly immune once vaccinated, or is it still possible to pass the virus to others unknowingly? And she's asking because you're still required to wear a mask and you're required to test negative before re-entering the country.
Well, the efficacy is 95%, which means that 5% of people who get vaccinated develop COVID. So, and some people are asymptomatic. So, and asymptomatic people can transmit it. What we don't know is how likely, if you've been vaccinated, how likely it is that you can transmit COVID. We'll find out because we're tracking that now. So I would say, yes, you need to wear a mask.
Now, is that number, and forgive me, is that number, when you say 5%, is that a real number, or is that just because you can't say 100%?
It's a real number. So the way they determine efficacy is that they vaccinate 100 people, and they vaccinate, and 100 people are not vaccinated. So they go back in the community, and over time they see how many people develop COVID in the vaccinated group compared to the non-vaccinated group. And the vaccinated group was 95% protected, assuming the same prevalence among, because we have so many people, you have a good idea that it's random. So you're 95% less like, well, you're 5% of the people develop COVID, 95% fewer than the non-vaccinated people. So it's a real number. So one is 94.1, the other one is 95%.
Okay, so it's a real number. Okay, great, yeah. Thank you. So when will the vaccine be available to patients with underlying issues, ages 16 to 65?
I don't know for sure. It all depends on how much vaccine the government can buy. I suspect the plans are by June, July, we would have vaccinated a large portion of the population, but that's the current plans.
Okay. All right. And now, Dr. Jackson, you and I had spoken, so if you wanted to share, like when we talk about summertime and people besides the non-essentials starting to get it and the need, so how is that going to help stop the spread of COVID?
End game here is to get a sort of what we call herd immunity. That's the end game. We want to get so many people that are immune because of the vaccine that the spread stops. So come the fall, I think that's when the numbers will start to roll in, early fall, of what our immunity is as a community. That's what we're looking for. So when the vaccine opens up for everybody, I don't know if it's going to be a 1C or a 2 or a 3. I mean, right now we're in 1B. But once it opens up for everybody, we're looking for the majority of people to get educated and hopefully decide to take the vaccine. The more people that take the vaccine, the quicker we will get to that immunity level that we're looking for. And you can kind of relate that to childhood vaccinations. If you have children that get vaccinations. Now, I've never seen mumps, I've never seen measles, I've never seen Haemophilus influenza. There are a lot of things that I haven't seen because we have this herd immunity because so many kids get the vaccine. So it's not just, so if it pops up, I might not know what it is. I mean, I'll have to open up a couple books, call Dr. Deborah Desire, call Dr. Gary Desire, I don't know, because I might not know what it is. But that's what you call herd immunity, and that's what they were referring to when that past administration was talking crazy about let us all get it to get a herd immunity. No, that's not how you do it. Vaccination is the best way to get those levels to a place where new infections and spread get to the point where we're like, hey, we're out of the pandemic. And that's what we're looking for. That's what we're pushing. And that's what, when they open it up to everybody, that last push of the rest of the people to get the vaccine to get to that level. And I'm hoping, I don't know, the fall, Dr. Gary, we might be having those numbers.
Yeah, I mean, you're right. If all goes well, we would have the ability to vaccinate the majority of the population. So you need about 70 to 80% of people vaccinated for herd immunity. And we can do that. And we'll have enough vaccine by the summer, I hope, and we can do that. So that would be the goal. One other thing, this vaccine is a lot more effective than the flu vaccine. The flu vaccine is only about 40%, 50% effective. And we don't think about, we don't. So it's potentially actually a very, very good thing if we can get the majority of the population vaccinated.
We hear the term herd immunity a lot, and I remember when your former president called it herd mentality. But what herd immunity basically means is that if I'm susceptible to a disease, and because I have no immunity to it, or because I didn't get vaccinated for whatever reason, or maybe I'm a child and I have some contraindication to being vaccinated, it means that when I walk around in the community, I still won't get the disease because nobody else is spreading it. And that's how you have to think about herd immunity. So what we want to do is get enough people who won't spread this disease so that everybody who's susceptible won't get it.
So thank you for that. And I'm laughing because I remember reading something on Facebook, these people having a discussion, and someone said the herd immunity means just let people, old people and sick people die. So I feel so much better now.
That's what the crazy people wanted to do. That's what the crazy people wanted us to do. They wanted us to do that.
I feel so much better. Thank you. I feel a little smarter too. I appreciate it.
So here it is. There are two ways of achieving herd immunity. You can get it in both ways. One is to let everybody get infected, and lots of people will die. This is one plan, but that's not the plan we want. We want the plan for people to get vaccinated and to develop herd immunity, not to let everybody get infected.
That's what the My Pillow guy wanted.
Exactly, right. That's the My Pillow guy plan, yeah.
In all seriousness, the Lieutenant Governor of Texas basically said that the old people should be willing to die so that we can save the economy. And my thought was, I don't know about your grandchildren, but mine like me. So we're not doing that.
Yeah, I think we can agree that we're not going to do that, right?
Yeah.
All right. So we got about 10 minutes. And we got a couple more questions, and I also want to leave time for you to give us some closing thoughts. So people in the audience, if we don't get to you, we do apologize, but our conversation has been so rich, so we appreciate you. Once vaccinated, how long are you immune to the virus?
Probably 90 days.
Um,
Probably.
once vaccinated, the immunity appears to be about 8 to 9 months.
Oh, okay. All right.
So if you
I'm sorry, I heard if you have COVID.
Yeah. You know, as a communications major, that is my fault, because as the sender, I should be making sure the receiver is clear. So I do apologize. So thank you for that. Both those answers.
Yeah.
So to all of the doctors, as we wait to get vaccinated, what should we do to stay safe? Top 5 safety keys.
Keep seeing your family and friends on Zoom.
Wear your mask.
Wear a mask. Wash your hands. I don't know all these people who weren't washing their hands before COVID, but
We know who that was, but go ahead.
So wearing masks is really important, particularly now that there's a new strain that appears to be more effective in infecting people, and it's about 50% more effective. And the way to prevent that is actually to wear masks. Wear the best masks available. You know, there's a lot of talk in the lay press and among medical community, which masks are better. So there are better masks. So I would say get the best mask you have available and wear that.
But I can't stress enough this idea that I have my safe pod and that my friends can come over, and you know, it just is not, it's just not a fact. And I think that until this thing is under better control, right now the biggest spread is small groups in people's homes.
Okay.
As someone who normally hosts 40 people for a sit-down dinner for Thanksgiving, this year it was me, Gary, and the family Zoom. And I think that it's hard, but you want to be around next Thanksgiving to see people.
Absolutely. So I think to that previous question about how long, does that mean after 8 months we need another vaccine?
We don't know yet. Remember, the vaccine is brand new, so we are what they look at is how long the antibodies you make persist in your blood, and so far they've been around for up to 8 months. But we don't know. It might last longer. The other thing to consider is that the virus will change over time, just like the flu changes every year. So you have to create a new vaccine. So you may have to get vaccinated every year, because the antibodies you had before are not effective because the virus has changed, just like we do for the flu. You're muted.
Yep.
Yeah.
I think you answered 2 questions at once. So, because Brother Charles asked, what happens when the virus mutates? Will you have to wait for a new vaccination?
So the virus mutates all the time, but many of the mutations have no effect on the vaccine or on the therapeutics that we have. So we track the mutations and figure out whether or not the vaccine is still effective, and also whether the therapeutics are still effective. So Moderna, for instance, is thinking about creating a booster shot for the new variants that have come up. So you might have to take a couple of booster shots over time. They can do it because of the way they created the vaccine. So there's a lot of background work ongoing now and surveillance ongoing just to make sure that the vaccine remain effective.
All right, well, great. Well, I think I'm going to give you one more question, then I'll give you all opportunity to give some parting words, and we'll wrap up the program. Do we know how effective is the current vaccine is for the newer strain of COVID?
It appears to be effective.
Okay. All right, well, great. So listen, we could probably do this all night, but we want to we thank you for giving of your time. I told Dr. Jackson earlier, I said when I asked her if she could get some panelists for her, she came back with some heavy hitters. And this tonight was a great panel. We appreciate all of that you do, number one, but also for sharing all that information with us. I jokingly, and I'm not joking because I'm up for the vaccine and I was reluctant, but you all gave me so much to think about tonight, and particularly the risk versus the risk of getting COVID. And with that, I will ask, starting with, I guess we can go in reverse order, and we'll start with Reverend Ross Lee to give us some parting words.
Okay. I'm trying to find something. Oh, yes. As a part of the 1916 project, Evelyn Hammonds, who was a historian of science at Harvard, said that there's never been any period in American history where the health of Blacks was equal to that of whites. Disparity is built in the system. That's one of the reasons why people are hesitant, and that is a reason why we need to change that reality.
Thank you. And you touched on so many things in that area tonight, and I think that's the reason why we wanted you here. So we appreciate you sharing your thoughts this evening.
Thank you.
All right. Dr. Jackson MacArthur.
I thoroughly enjoyed myself. I think my parting words for our community is to get educated. I'm not here to tell you have to take the vaccine, but what I am here is to help educate you so you can make a decision based on facts and not myths or untruths. So education is key, and don't be afraid to ask questions. That's a very good point, to talk to someone that you trust.
Great. Thank you, Dr. Jackson MacArthur. Dr. Deborah Desir.
Well, I guess my parting words are thank you. Thank you to the brothers of Epsilon, Iota for all you do and for putting this together. Thank you, Dr. Jackson, for inviting us tonight. I'm really grateful to have had this experience. And thank you to everyone who attended, and spread the word. You guys are so gracious in we're not telling you what to do, but I'm slipping into my mother mode, and yeah, you need to get the vaccine.
Well, at least thanks for doing it at the end. And finally, Dr. Gary Desir.
Well, I want to thank you for inviting us and giving us a chance to talk and hear concerns and try to address some of them. I would say that one should continue to advocate what you believe is in the best interest of the people who trust you, and that's what I try to do. And I would also say that it's helpful as you interact with the health system to have an advocate with you. So I always recommend my family members and friends, when they go to the hospital or go see a physician, bring somebody with you as an advocate. When I myself go and interact with the medical system as a patient, I'm often not thinking as a physician. So I always have my wife around just to make sure I'm being treated properly. So having an advocate, if you can, is always a good idea. So.
Well, great. This was so enlightening, but also so powerful. So it was much needed. We sometimes think that we know, but a lot of times we don't know. And me personally, I have learned so much this evening, and I'm hoping the audience got something out of it as well. But again, I'm just so grateful to all four of you for taking the time to be with us here tonight. And as we push forward, we may do this again, and so hopefully we can call upon you. And you're always welcome back. And with that, I would like to turn the program back over to our boss list, Brother Alexander Jones.
Thank you, Brother Walton. In closing, I would like to thank our panelists, not only for their expertise, but for their time as they've come together and presented a great presentation and program on this vaccine. I'd like to thank Brother Walton, our Social Action Chair, and his committee, who's done another excellent job. And I'd like to also thank the attendees for coming and viewing this program with us. Everybody get home safely and have a good night.
All
Thank
right.
you.
Thank you very much.
Thank
It was a
you all.
pleasure. All right.
Good night, everyone.
Bye-bye.
Stay safe.
You too.
Thank you. AJ, are we staying on?
Yes, if we could just stay on for just a brief minute. I have another meeting as well.
All right,
after
give
10,
me,
but
yeah, give me a minute, bro. Woo. Oh my goodness.